Everyone. Welcome to the COVID-19 office hours tele-echo session. We're really excited to see everybody and welcome back. Well, Nestor, we're happy to have Nestor back today. Just a couple of housekeeping announcements. If you have a camera, we would love to see your face, so please leave it on if you can. I understand that all of you can't, but we would love to see your faces if we can. We would also ask that you keep yourself muted during the session unless we call on you to ask your question or call on you with a question. And if you have a question during the session, please put it in the chat box. So great, I think we're gonna go ahead and get started. Actually, we have a presentation by both Nestor, Leslie, and Marla today. So we have a lot of presentations. So I believe I will turn it over to Nestor now and he can introduce himself and go ahead and start with his slides.
Sure, thank you very much. I'm glad to be back here. Let me see if I can share my screen. Okay, let me put this in presentation mode. Okay, here we go. So okay, so I'm going to review different articles that I was lucky enough to read during my 2-week vacation. First of all, this publication, it's a research letter that was published in JAMA Network, Outcomes and Mortality Among Adults Hospitalized with COVID in U.S. Medical Center. This is sort of after 1 year of a pandemic, it's sort of a review of the survival and by age and also by month throughout especially the initial phase of the pandemic. And I found it was very interesting. There's definitely this clear-cut difference in the survival probability and age. And you can see that subjects that are over 80 had almost 30% mortality or 70% survival when they develop COVID. So almost a 30%. And this proportion of the survival increases the younger you are. So there's a clear-cut relationship between the age. And this is a study that included almost 550 medical centers in the United States, more than 292,000 patients. And the other interesting phenomenon, which is encouraging, is the fact that the late in the pandemic, the better the survival. You can see that the worst survival was March, the first month of the pandemic in the US, April, and then the closer you get to the present, the higher the survival. And that basically translates the learning curve from the physicians managing these cases, the availability of remdesivir and dexamethasone and other interventions like anticoagulation and proning. So we got better, we definitely got better at saving lives during the pandemic, and this graph really summarizes that. So they're an interesting paper. Talking about vaccines and variants, which is like the hot topic, there was a publication last week in the New England Journal in which they took serum from 20 subjects that had the Pfizer vaccine. This is the Pfizer vaccine, 2 doses of the Pfizer vaccine, the BNT162b2. And they actually constructed viruses, pseudoviruses with the spike protein of the different variants, the original USA Washington 1, which is like the wild type original strain that circulated in the US, the UK or B117 spike protein, the P1, which is the Brazilian, the South African, and others of the South African with some deletions. And the take-home message of this study is that there's still a pretty decent, according to this study, which was sponsored by Pfizer, a pretty decent activity or neutralizing activity of the serum of vaccinated subjects against most of the variants, obviously with a significant drop in the ability to neutralize the virus that has the South African. So the South African is definitely the most concerning, even more than the Brazilian, that is very, very similar regarding the number of mutation. But there's definitely the South African seems to be the troubled child. And not only that, there's also evidence, as we know, that the Novavax vaccine, the Johnson & Johnson and AstraZeneca had a significant drop in its efficacy in the clinical trials when the patients were enrolled in South Africa, where the variant was most prevalent. There's another study that I will review next week that shows an even more worrisome picture with this variant. It's definitely less susceptible to inhibition by the antibodies produced by the vaccine. But the good news is that the strains that are circulating in Europe and the US, the original one and the other, the UK variant, are still very susceptible to inhibition or neutralization with the current vaccines available to us. The other strain that I haven't really talked about is the strains that have been isolated in California, and they are actually two lineages, 427 and 429, and the main characteristic is that this mutant or this variant has three mutations in the spike protein. The most important is the 452, which is very close, and this is the spike protein and the ACE receptor. And although this is not exactly in the area where the ACE receptor and the protein interact, it does changes the conformation or the characteristics of the protein very close to the RBD, to the receptor binding domain. So it's thought to be important. And these two lineages from California are definitely becoming more frequent. And this graph in the middle shows how it was basically 0% of the isolations in September, and now it's up to 50%. And that is sort of an indirect indication of its transmissibility, that is probably more transmissible than the old wild type virus. And also when you compare the amount of virus in the nasopharynx of the patients who had the non 427, 429, so the old variants with the new variants, the CT value, it's lower, meaning that they have a twofold higher viral load in their nasopharynx. So although probably not as concerning as the South African variant, this is definitely an evolution of the virus that has been detected in California that seems to give higher transmissibility or be associated with higher transmissibility and higher levels of virus in the nasopharynx. And when you look at the capacity of vaccine recipients to neutralize the variant, specifically the 429, and also convalescent plasma neutralizing the 427, you can see that there's a drop in the levels, a drop that it's around 4 to 6-fold less susceptible to neutralization. So this is definitely a variant of concern because it's less susceptible, more transmissible, maybe not to the level, as I said, of the South African, but it's definitely something that especially if it accumulates more mutation or maybe acquires the 501 mutation present in the UK may be more troublesome. So in conclusion, it has an increased incidence, have become very frequent in the California area and other areas in the United States. It's associated with increased transmission, higher viral load or viral shedding, and decreased neutralization activity of convalescent plasma, and also serum from vaccinated subjects to some degree. The other important, I think, information I actually took from a presentation that was given by Tom Shimabukuro from the CDC COVID Vaccine Task Force. As you know, we have this: when you're vaccinated, you give your information about vaccination and using the Be Safe and the report the virus. There are a couple of reporting systems. They have accumulated 30,000 subjects that became pregnant or were pregnant when received either the Moderna or the Pfizer vaccine. So at least we have some information on 30,000 pregnant females on this voluntary registry, the Be Safe. And the good news is that there was no safety red flag, no safety issue with the reception of the vaccine and pregnancy. In fact, miscarriage, which was the most frequent event, was present in 15% in this registry, but the background of the normal incidence is 26%, according to what's known here in the U.S. So it's really no significant alert or any safety signal regarding pregnancy, which is obviously encouraging. Some other vaccine adverse reaction. There was a publication in the New England Journal of 12 cases of delay large local reaction. And you probably, if some of you were here a few weeks ago, we had a case presented of a delay reaction. So this has been now more officially recognized or reported. These patients had like a delayed hypersensitivity reaction with the first dose, which consisted of an induration in the area of injection and some systemic symptoms. And you can see some photos of these. And this is not the immediate allergic reaction. This occurred usually 8 days after the initial injection or after the initial vaccination. And in fact, all of these subjects went ahead and had a second dose. And as you can see, 4 of them have no recurrence of the rash, and the rest did have recurrence of the rash. But it was not significantly more severe. It was not more severe. So it's not a contraindication for the second vaccination, but it's something that has been recognized. And the authors mentioned that they did a biopsy of some of these subjects, and they found changes consistent with a type 4 delayed hypersensitivity reaction. So this is not a type 1 histamine mediated. It's actually like a T cell late reaction to some of the components. We don't really know to which of the component of the vaccines, but it's something that had been reported, and we even discussed a case of this in this ECHO session, in this office hour sessions. And this is more a curiosity than anything else. There was a case of a 60-year-old woman who actually got her first dose, and the day after the first dose felt really ill with fever, weakness. She was like falling frequently, and I think she had a history of an underlying malignancy, and they decided to do, because of her presentation, they did a PET scan. Obviously not indicated with the vaccine, but it's interesting that the PET scan actually lit up in the shoulder, which she got the vaccine, and you can see the bright area here in the arm. This is the arm, this is the neck, this is the other arm. There's obviously an inflammatory reaction or uptake of the radioactive glucose here, and also in the axillary lymph nodes, which is logical, and even in the spleen. She had the spleen was actually brighter, normally it's less than the liver. So that meaning that there's activity, there's immune activity or immune activation after vaccination in the regional lymph nodes and the spleen. It's just a curiosity that I wanted to bring. And the patient actually recovered from her reaction, but it was interesting to that they, incidentally did a PET scan on this patient and documented the different areas where the immune reaction or immune response to the vaccine is occurring. So they saw the spleen, the lymph nodes, and obviously the arm where the injection took place. Finally, there was a study, an RCT on ivermectin. As you know, we have been discussing, especially in Latin America and some countries in Europe, they have been advocating for the use of ivermectin because of in vitro activity against COVID. So a group in Colombia published in the JAMA the effect of ivermectin on time to resolution of symptoms among adults with mild COVID. They actually treated over 400 patients, and they found basically no difference in the time to recovery using ivermectin. So a negative study, well-designed study. It was double-blind, randomized, placebo-controlled, and they were unable to demonstrate any benefit from ivermectin, any significant benefit from ivermectin. So, there are some other studies taking place, but at least it's another negative piece of information regarding ivermectin that it was necessary because the other studies were not of high quality. So this was a high quality study, but negative result. And the other point, which I think it's one of the more controversial points, is if the vaccines actually decrease transmission. And we have talked about this, and I wanted to bring a couple of papers that are already showing some of that evidence. The first paper, it was a pre-publication, actually, is the SIREN study that I have presented here before. The SIREN study is sort of a cohort of healthcare workers in the UK that they have been followed, and the SIREN published on their immune response to COVID, etc., and the risk of COVID among healthcare workers. But in this case, they actually evaluated real-life effectiveness of the vaccine, because the healthcare workers in the UK have been vaccinated, and they analyzed specifically those who received the Pfizer vaccine, and they found an 86% vaccine effectiveness in preventing both asymptomatic and symptomatic infections. So it's one of the first clear evidence that the vaccine not only prevents symptomatic, but also asymptomatic. These subjects, this healthcare worker had like a serial PCR of their nasopharynx. So they were followed to see if they developed asymptomatic infection, and they compared with the unvaccinated healthcare workers, and there was definitely an 86, a very significant protection, very close to the same efficacy that was seen in the clinical study. That was 95 in prevention of both asymptomatic and symptomatic. And also, we knew some of that from the documents that were presented to the FDA by Johnson & Johnson. They had a table in that dossier that the Johnson & Johnson vaccine, despite being just one dose, they found a vaccine efficacy to prevent asymptomatic disease of 74%. So at least we are accumulating more and more data that the vaccines are conferring protection not only against symptomatic but also asymptomatic. And asymptomatic is important because it also decreases transmission of the disease by decreasing the asymptomatic infection. And finally, this other study, single dose of also the Pfizer vaccine by Dr. Weeks, in which they actually analyze unvaccinated subjects and subjects 12 days post-vaccination, and they found much less incidence of asymptomatic infection. And not only that, those few are the blue dots here, those few that develop infection, their CT value was much higher, meaning that they have a lower viral load than those who develop infection being unvaccinated or early after vaccination. So apparently the vaccine not only protects against asymptomatic infection, but also confers, if you develop COVID, you're going to have a smaller or lower viral load, and that can probably translate into less transmission. So good news from the point of view of the vaccine. Obviously, there are still infections. So the other analysis you can make is that, it's not 100%, and that's right. So even after vaccination, we need to continue the masking and social distancing to some degree. But definitely, it's positive data that we didn't have before with the Moderna and Pfizer vaccines. Finally, in the news, there are a couple of mentions of new monoclonal. There's a new monoclonal by Vir Biotechnology and GSK are presenting, and they show that their monoclonal called Vir 7831 decreased hospitalization by 85%. So very similar to the bamlanimab, etesevimab, and the Regeneron. And actually, Lilly also published the result of the phase 1 and also confirming the finding 87% less hospitalization and death in the press release. We have to wait for the publication. So there's more data accumulating on the benefit of these drugs to prevent hospitalization and death if given early in COVID infection. And finally, there's an oral antiviral, molnupiravir, that showed clearance of the viral shedding in 5 days, complete clearance of viral shedding in 5 days. And this is an oral antiviral, and it's still on the research, but the phase 2A randomized double-blind controlled trial performed by Merck showed that benefit, and we'll have to wait for the phase 3 and the publication of this trial. But it's actually good news that this oral drug, and it's the first oral drug, direct antiviral that can inhibit viral replication and also decreases the viral shedding, and hopefully will be associated with clinical improvement. That's it. That's all I had to share. I know it was very long, but I've been away for 14 days. So.
Thank you so much, Nestor. That was excellent. Leslie, can you go ahead and introduce yourself and go ahead with your update? Thank you.
Sure. Leslie Hayes, family medicine and addiction medicine in Espanola, New Mexico. Thanks, Nestor. That was really great. And I am going to talk first about the COVID vaccine and if it'll help or aggravate long COVID symptoms. Hang on. So patient came in to see me this week, 46-year-old woman. She had COVID in October. She's had really horrible symptoms since then, multiple rashes, including burning, flaking, dry skin in her ears, which she just said is completely making it hard to do anything, brain fog, headaches, neuropathic pain in her scalp, numbness in her left arm, loss of taste. She had loss of smell until a couple of weeks ago, and that finally has resolved. I had a visit with her this week, and just out of the blue, she said she didn't want the COVID vaccine until her long COVID had improved. And since I personally am hoping everybody gets the vaccine, I was a little bit worried about this. So I tried looking up to see if there were any official recommendations on this. So first thing is, for nobody at this point actually knows for sure what causes long COVID symptoms. I mean, some of it we do. If you had a lot of scarring in your lung related to pneumonia, obviously that's that. But you know, the brain fog, the neuropathic symptoms, the loss of taste and smell that persist, we're not quite sure why those are there. And I did find NIH in February just announced a new initiative. They have 1.15 billion over the next 4 years to support research into the prolonged health effects of COVID, including figuring out what the underlying biological mechanism is. So hopefully we'll get some answers on this at some point soon. So I tried looking to see whether or not there was any actual data on this, and I did not find any actual data. So I'm a little embarrassed to admit that I'm citing Facebook polls, but that was as close as I could come to any actual studies on it. So there were 2 informal polls. One of them was cited in the US News article for some COVID long haulers, symptom relief after a vaccine. And a woman, Allison Finley, who has post-COVID, found that her symptoms actually got better after vaccination. So she just did a Google Forms survey, and she's gotten 68 responses. 32% of the people who responded reported an improvement in their long haul symptoms. 53% said no change, and 15% reported feeling worse. So 85% did actually fairly well, and just a small percentage worse. And certainly a third actually felt better. So this guy is Jez, I don't know how you say it, Medinger, and he actually is a film producer in the United Kingdom who developed long COVID about a year ago. And so he's gotten very interested in it. And he had a YouTube video posted on February 23rd of this year, and first vaccine reaction data for long COVID. And he actually, for being a film producer, he fully acknowledged all the limitations, actually got someone to do statistical analysis on his data. He polled 473 people on long hauler groups on Facebook and Slack. Going along with what we know about long COVID, the majority are female, the majority are between 41 and 60, and the majority had symptoms for 9 to 12 months. He asked people about how they were doing 2 weeks after their shot, 2 weeks or longer after their shot. And the numbers were actually fairly similar to the other poll, that 50% were at baseline after 2 weeks, 27% were better, 5% were almost well, 14% were moderately worse, and 3.8% were much worse. So, you know, this is not by any means data, but it actually was kind of reassuring to me. And I sent this information to my patient, and I told her I would recommend she get the shot. This, who knows if this will actually play out, but people who got the Moderna or Pfizer did better than people who got AstraZeneca. More people were claiming to feel worse after getting AstraZeneca than after getting Moderna or Pfizer. And then the other one, I've actually been wanting to look this up for a while. And Elaine Gush sent me an article this week that I'll include at the end from The Atlantic, but they talked a lot about postural orthostatic tachycardia syndrome, or POTS. And I initially learned about POTS when one of my daughter's friends in college developed it. And it's a syndrome where people get very tachycardic and lightheaded when they stand upright. No hypotension. It's not the same as orthostatic hypotension. They just get the fast heart rate. It's believed to be a dysautonomia, where the autonomic nervous system isn't functioning correctly. And it was really kind of scoffed at, I think, up until COVID, just because it tended to hit young women, and those young women are often considered a little bit flaky, and the symptoms of this are kind of things that, you know, are thought of as a little bit flaky. So I don't think it was really taken seriously. But now it has really become clear that POTS is much more common post-COVID, and there's definitely seems to be an association with COVID-19 and all of the dysautonomias, but in particular with POTS. POTS also occurred more commonly with other viral syndromes. So the diagnostic criteria, you need a sustained heart rate of at least 30 beats per minute, or more than 120 beats when you stand up, or if they do the tilt test. So just basically check orthostatic vitals in your office, have the patient lie down, have them stand up, and see what their heart rate does during that time. It's also important that they not get hypotensive when they stand up. If they get hypotensive, that actually rules out the diagnosis. They also should, When they stand up and get the tachycardia, they should have the symptoms that they were complaining of, such as lightheadedness, palpitations, tremors, weakness, blurred vision, fatigue. And sometimes they may actually pass out because of their symptoms. And oops, put the reproduction twice in there. And then they should have absence of any other conditions that provoke sinus tachycardia, such as anxiety disorder, hyperventilation, anemia, fever, all the things that normally cause people to get tachycardic. In addition, they should not be taking any medications that could cause any of these. So some of the other symptoms of POTS are interesting because these are actually very common symptoms of post-COVID. So I thought I need to be screening more of my post-COVID patients for POTS to see whether or not this is what's going on. Severe or long-lasting fatigue, lightheadedness with prolonged sitting or standing, brain fog, forceful heartbeats or palpitations, nausea, vomiting, headaches, excessive sweating, shakiness, intolerance of exercise, or prolonged worsening of general symptoms after increased activity, and pale face and purple discoloration of the hands and feet if the limbs are lower than the heart. And treatment, you want to withdraw any medications that are likely to make them feel worse, increase fluids, increase salt, put them in compression socks, and then exercise therapy. But exercise therapy, you can't just send them out to exercise because they're going to feel worse. And actually, the more I read about this, it just seemed very complicated as far as how to encourage them to exercise. So my recommendation would get somebody experienced in dysautonomias if you're going to have them exercise. And then pharmacologic, they talk about blood volume expanders, fludrocortisone or desmopressin, IV saline, and they said you can actually, some people will get an infusion of saline a couple times a week, which I thought was interesting. And then erythropoietin, which I must admit would make me a little bit nervous to use for this. Heart rate inhibitors, propranolol is actually the one I've seen most commonly used for this. And then if the propranolol doesn't work, a medication that I'd never heard of before called ivabradine, which apparently helps to slow down the heart, and then pyridostigmine. Vasoconstrictors and sympatholytic drugs also work. And then just a couple articles that I thought were useful. The first is the one that I mentioned earlier that Elaine had sent to me, Unlocking the Mysteries of Long Haul COVID in the Atlantic in April. And this was an excellent article, one of the best I've seen, sort of going through long COVID. And they do talk actually a lot about POTS in there, which was what finally motivated me to look it up and do this. Then the second one actually is from last July, and I came across this for another talk I was writing, and it's on how do we prevent future pandemics. And it was the best summary I'd seen of it. And they pointed out it would cost somewhere between 20 and 30 billion to prevent the next pandemic. And so far it's been over $5 trillion that they think we've lost in 2020 from the pandemic. So definitely worth preventing the next one if we can. And that was all I had.
Thank you so much, Leslie. Let's go ahead and go to Marla. Marla, can you introduce yourself and share your slides?
Hi, sorry, I'm going to try that again. All right, hopefully you can see my slides. Great.
Yes, we can.
All right, so Marla Seaver is an infectious disease epidemiologist with New Mexico Department of Health. And I'm going to review some of the changes to the CDC guidance for vaccinated folks. So you may remember a couple of weeks ago, we talked about some updated quarantine guidance for vaccinated people. And they updated that guidance last week to remove a piece that, if you'll remember, we talked about, we weren't sure why it was included. And this was the recommendation that people be exempt from quarantine if they were within 3 months following the receipt of their second dose of vaccine. So that's been removed now, that 3-month time frame. And the new quarantine guidance does not contain a time frame for post-vaccine. So as long as you're fully vaccinated, meaning you're at least 2 weeks from your second dose of the Moderna or Pfizer vaccine, or 2 weeks from your J&J vaccine, you're considered fully vaccinated and you do not need to quarantine following exposure to a confirmed case. However, all of the other infection prevention mitigation measures should remain in place. such as masking and distancing and avoiding crowds. So there are some exceptions to this quarantine guidance for people who are in congregate settings and healthcare. So here's two of the statements from the CDC guidance. So if you live in a group setting, like a correctional setting, detention facility, or other kind of group home, and you are exposed, you should continue to quarantine for the full 14 days and get tested regardless of your vaccination status or your symptoms. And similar recommendation for hospital inpatients and residents and staff in long-term care settings. So in these high-risk settings, we have more opportunities for transmission and a more vulnerable population. Quarantine is still recommended regardless of the vaccine status. So, but once you've been fully vaccinated, if you're not in one of these congregate settings, there are now some additional things you can do. So again, fully vaccinated more than 2 weeks after your dose, and continue all the other public health prevention measures when you're in public spaces. But once you've been fully vaccinated, you can now visit indoors with other fully vaccinated people without wearing a mask or physical distancing. Indoor visits between fully vaccinated people are thought to be of low risk. So an example would be inviting other fully vaccinated friends or family members over to your house for dinner. So, emphasizing that you're in a private setting, not a public setting. You can also visit with unvaccinated people from a single household who are at low risk for developing severe disease. Again, indoors without masks or physical distancing. So indoor visits between fully vaccinated people and unvaccinated people are likely very low risk for that vaccinated person. So an example might be inviting grandma over to dinner after she's fully vaccinated, knowing that she might be mixing with adults and children in that household who, some of whom may be vaccinated, some of whom aren't. However, the risk to that vaccinated person is thought to be low in that setting. If any of the unvaccinated people in the household are at increased risk for severe COVID disease, then everyone should take precautions, such as visiting outdoors if possible, making sure you're wearing a well-fitting mask and maintaining physical distance. Visiting with people from multiple households is a higher risk activity, obviously, and therefore all people involved should take precautions, including wearing a mask, physical distancing, and visiting outdoors or in a well-ventilated space whenever possible. So, one of the things in the CDC guidance that they sort of continue to emphasize is keep your gatherings small. If you're going to mix people from multiple households, do it outdoors if possible. And if you can't do it outdoors, then people should continue mask wearing and distancing. You should continue to avoid medium or large gatherings, and if you participate in social activities in public settings like going to the gym or dining indoors in restaurants, even if you're vaccinated, you should continue to follow all the precautionary measures, wear a mask, maintain physical distance, avoid crowded indoor spaces, and make sure you're washing your hands frequently. So this was a pretty modest update from CDC about what activities fully vaccinated people can engage in. However, they did emphasize in a couple of calls I was on last week and over the weekend that we should be expecting additional changes to this guidance in the coming weeks as we learn more about vaccine effectiveness and as more of the population becomes vaccinated. So keep an eye on these changes because we're expecting them to continue to be updated week by week. And travel guidance for fully vaccinated people, CDC is still really trying to hold the line on travel and recommend that regardless of your vaccination status, you avoid unnecessary travel, stay home if possible. If you must travel, they do recommend that you are tested prior to your departure date. And obviously, if you are infected, that you not travel. But assuming you have a negative test, continue to wear a mask, avoid crowds, at your travel destination, and then get tested again when you return home. So following your arrival at home, you should self-quarantine, get tested 3 to 5 days after your trip. And then obviously, if you test negative, no need to continue that quarantine past the 7 days. If you do not get tested, then you should stay home and self-quarantine for a full 10 days after travel. And if you develop symptoms during that 14-day post-travel period, make sure you get tested and isolate from others. So again, what hasn't changed? Recommendations for use of personal protective equipment by healthcare providers remain unchanged, regardless of vaccine status. So any PPE that you're wearing in a clinical setting when treating COVID positive or COVID suspect patients, that recommendation for healthcare providers has not changed, regardless of their vaccine status. People should continue to follow the testing guidance at their workplace if you work in a place that is undergoing routine surveillance testing, regardless of your vaccine status. And even though you're vaccinated, you should still continue to watch for signs and symptoms of COVID-19, especially if you've been around someone that you know is sick. And again, if you develop symptoms, you should be tested and isolate pending your results. And then just a couple of links for further reading. Here's a science brief from CDC that kind of underlies their changes to the recommendations. So kind of their rationale for the changes that have been posted so far, and some additional reading for infection prevention professionals in healthcare settings.
Thank you so much, Marla. Before I get into the questions, I wanted just to ask, Cecilia Thompson is on from Tricor, if you have any updates from a testing standpoint before we get into the question section.
I don't have any updates, but I'm happy to take questions.
Great, thank you, Cecilia. And I completely forgot to mention when we started about our digital librarian, Kent, is putting all sorts of incredible information that's being discussed into the chat. I'm sure you've all seen it, but please take advantage of that as well. So Marla, I wanted to start with you. Just some questions came in while you were talking. Eva Angeli asked regarding visits at nursing homes, could a vaccinated resident have physical contact, hug, with vaccinated adult family members?
Yeah, so there were some significant changes to the nursing home restrictions that are included in that second link in my slides for further reading. I didn't go into today because they're quite detailed, but the short answer is yes. Vaccinated residents can have indoor visitation with friends and family members, regardless of their vaccine status. People should still be masking, performing hand hygiene, but they can have touch and indoor visits with this new guidance after being vaccinated.
Thank you. And when you were talking about congregate settings, do college dormitories count as congregate settings?
Yeah, CDC did not include college dormitories in their congregate setting guidance. And it was something we actually talked about here as well. Did we think they should be included? And we were kind of split in EPI, whether we thought they should count as a congregate setting or not. Obviously, most younger people are not going to be vaccinated yet. However, it is a group which is at lower risk, for developing severe disease, which is why I think CDC did not include them in that guidance. They have the ability to, come and go much more frequently, unlike people who are really confined in those other congregate settings like jails or prisons, or nursing homes or other detention facilities. So they're treating college dormitories much more like a private residence than a college setting in the current guidance.
Great, thank you. And Elaine Struthers asked, would this quarantine guideline apply to public school workers? I think she meant that one, or public school, people who work in public schools, treated differently?
I haven't looked at the most recent public education department guidance, so I don't know if New Mexico PED has adopted these quarantine recommendations or if they're retaining the old standards. So I'm sorry, I haven't looked at that to be able to answer.
Great, thank you, Marla. And I know you answered this in the chat when Jeff Miller asked about how people can start seeing more patients in person in their health settings, and a couple of other people have asked. So I don't know if you just want to go over what you do know and what's not known.
Yeah, not much has changed in the CDC guidance regarding outpatient care right now. They still recommend, using telehealth whenever possible. If people are coming into the clinic in person, make sure that you're screening them for signs or symptoms of illness or known exposures, again, regardless of their vaccine status, and recommendations that healthcare personnel are still, using all precautionary measures, face masks, shields, gowns and gloves when needed, to protect themselves, again, regardless of vaccine status of those patients. So this may be an area that we start to see some updated guidance as CDC kind of rolls these out and harmonizes these pages over the next few weeks. But right now, there hasn't been any updates to that guidance.
Okay, and one more for you. Has there been any or any idea, any new information about when vaccine will be available for younger 12 to 16-year-olds? There's a couple of questions about that.
I know that there are some clinical trials underway right now with younger folks, and I have heard some people think that, we may be vaccinating down to age 12 by the end of the summer, but I don't think we know for sure yet. I don't know if Dr. Sosa or Dr. Hayes have other information.
Any other information, Esther or Leslie? No. Okay. I don't see Harry Seibold. Are you still there? I don't see you on my screen. Can you unmute yourself if you are?
I am. I'm here.
Okay. Do you want to ask your question about the Lilly product? Because I don't know how to pronounce it.
Oh, holy moly. You went way back to that one. I got to remember my question. Yeah. I wrote down so many questions on in there. Help me. Oh, I was just wondering, the Lilly combination product, does it have an emergency use authorization? And what are the parameters for the use of that product versus any of the others?
Yeah, I think it does. They added the combination now. It's very similar to the other. So it's, more than 65 or more than 55 with underlying conditions. So it's very, very similar in the way the FDA rendered the EUA for the combination.
And is there a difference, or do we know, has there been a comparison between the Regeneron and the Lilly products?
No, I haven't seen a complete direct comparison. They did compare with monotherapy or one of the monoclonals, and it seemed to be, better regarding hospitalization in some of the studies. But that's as far as I have seen. Just different doses of mono versus the combination. And now the Blaze one, which showed the news that I shared was 87% prevention of death and hospitalization in early COVID in patients with high risk of severe COVID.
Thank you. There's a question by Carol Miller about, she says, since we know so little about the link the post-infection antibodies last, is it helpful for people with antibodies to delay vaccination to learn more about the subject, like the lifespan of the antibody and the protection of the antibody? I don't know, Nestor, if you know anything about that or read anything.
No, I mean, the general recommendation is that even if you have antibodies, which means that you had COVID, that you should be vaccinated, because there's sort of a booster effect from the vaccine, even if you have already circulating antibodies. And in fact, the data, it's becoming more and more robust regarding the degree of increase in the antibodies after just one dose of the Moderna or Pfizer vaccine in those who had COVID. So there are governments, I mean, I haven't seen anything from CDC or FDA, but I can give you a couple of countries have already instituted that if you had COVID or you have antibodies against COVID, you only need one dose. Because basically to have another dose available for another person, not because it has been studied in any formal way, but it's just that because the reaction is so good with just one dose, if you had COVID before, that some of these ministers of health have recommended just one dose to have more doses for those who have not had COVID.
Harry, go ahead.
I just realized you were actually asking about the other question I had put in there about the molnupiravir. I had been hearing about this for a while now, but I hadn't heard the name of the drug, so I haven't been able to do any research. Do we know anything about this mechanism of action, if there's anything else in that class, and is it related to remdesivir at all?
Yeah, it is an inhibitor of the RNA polymerase, so it's similar to remdesivir, but not identical. It's an oral drug. We actually are about to start 2 studies here in New Mexico at UNM with the name of the drug used to be MK4482. So you're probably going to find a lot of more information with this MK from Merck 4482. That's the name, but it's now been renamed Molnupiravir. And this is the first piece of information that I see published, the fact that they show that their phase 2 study, they were able to show clearance of the virus in just 5 days in 100% of the 49 subjects. So, it's definitely encouraging. We are doing 2 phase 3, one in ambulatory patient that actually Deborah and Dr. Parada are going to participate. And we are going to do in the inpatient also. So for both inpatient and outpatient recently diagnosed COVID-19 subjects, we're going to use it and compare it to placebo, basically. Or with obviously with the underlying standard of care of remdesivir, dexamethasone for those hospitalized.
Do you have any ideas how long your phase 3 trial will last and how long it'll take you to do your data workup on that?
No, it's probably, I mean, they're moving really fast, but it's probably going to be 6 months at least to have some meaningful results, because they actually, at this moment, they're actually in a pause. They're analyzing the phase 1 and phase 2 data, and they're going to come up with the definitive dose for the phase 3. So it's in that break between the 2 studies in order to continue with the phase 3 in the different areas. And this is a multi-center, multi-country study. So it's not only here in the US, they're doing it in many other countries in Latin America, Southeast Asia, etc. And in order to try to gather, the information quickly. But my concern is that because the cases are going down, it may slow down the enrollment of patients everywhere, because of the relative decrease in the number of cases in different countries. So we'll have to wait and see. But it's definitely encouraging because it's oral, it's BID, seems to be well tolerated. There's no like red flags with what we have seen in the data. So it's really good news, and it's bioavailable, so you don't have to inject it like remdesivir or the monoclonals. But we have to wait really for the studies to be finished.
Thank you, Nestor. Linda Gorgos, do you want to just unmute yourself and just talk about them? Go ahead.
Thanks, Carly. Yeah, I was just going to add that our site in Santa Fe through Access Research will also have the outpatient treatment trial for MK4482. They're also looking at a prevention trial, so using this as an oral drug for household contacts to prevent infection. So we're applying to be a site for that study as well. And I think you guys had already mentioned the Vir product, the monoclonal antibody. Because of the interim monitoring board seeing clear clinical efficacy, that study is now fully closed to enrollment. They are applying for EUA, and they're planning to additionally look at that product for IM injection rather than having to give it by IV. And the Regeneron trial, which is active here in northern New Mexico, again, based on an interim data monitoring board review, saw clear clinical efficacy. And they have removed the placebo arm from the ongoing Regeneron treatment trial. So anyone enrolling now gets guaranteed treatment with monoclonal with the Regeneron product. So if you have patients who don't qualify under EUA, please refer them to us. We would be happy to treat them, and they are guaranteed to get monoclonal as part of the trial.
Thank you, Linda. Excellent. Leslie, Loretta Pierce is asking, are we seeing POTS in the elderly population post-COVID, or is it mainly in young women?
I haven't seen many case reports in the elderly, but I've seen a lot in, say, 25 to 50, which is certainly older than we're typically thinking of seeing it. So.
Thank you. And Deborah, do you want to unmute yourself? Can you give a little bit more what you're asking about the T cells?
Yeah, there was a new, I believe it was also emergency authorization for a test that can test potentially for long COVID. And I'm just wondering if anybody knows about that, or if that's something that's going to become available in the future, just to know if somebody has had COVID in the past, and to be able to help to diagnose long COVID, although that's such a broad topic.
Leslie or Nestor? Or
no, I have not seen that. I'm going to look for it. No, yeah. I haven't.
Cecilia, have you heard anything about that?
I have not.
Okay, great. Well, if something comes up, we can talk about it. Let's
Yeah,
see.
there was something on TWIV by Dr. Daniel Griffin had talked about it on, I think, Saturday.
Great, thank you. So Olivia Beckman, Marla asked, if the travel recommendations state that number 1 is to get vaccinated, does that mean that vaccinated individuals no longer need to get the pre and post testing?
No, the recommendation is that even vaccinated people pre and post test for travel.
Great, thank you. And I just wanted to let everybody know that that the CME link went into the chat about 5 minutes ago. So if you would like to get CME, please do that, and we would love to hear your feedback about the session as well. There was a question that was emailed in. Marla, I think that you're the person that this should go to. I think that what she was asking, because she doesn't have, sounds like she doesn't have audio or isn't able to speak online. She says that if some people were able to get their initial vaccines, and I think she's saying that they got them, we heard about all these people going to Amarillo. If they were able to get their initial vaccine somewhere else, how are they supposed to get their second vaccine?
So if you log into your profile on the vaccine registration website, there is a little checkbox where you can say, I've already received my first dose. And so that will update your profile, get you out of the bucket of people who are awaiting first doses and get you into the group of people who are awaiting second doses. When you click that box, it will ask you the date that you received your first dose and the product that you received, so that your profile gets updated appropriately.
Thank you. Thank you very much. And I think maybe Winnow or Linda, there's a question from Eva Angeli. Are there any clinical trials in New Mexico for kids less than 12? Did someone answer that in the chat already?
Yeah, I'm not aware of any vaccine trials through us. I don't know if other sites have them. The Regeneron monoclonal antibody does allow enrollment of pediatric patients. So we can actually enroll pediatric patients and we can enroll pregnant patients. They have 2 different cohorts.
Thank you. Deborah Hill, do you want to unmute yourself and ask your question about PPE? Do you have a microphone?
Yes, I'm sorry. Ms. Sievers answered it down below, so I think we're good. I just wanted clarification on one of her slides, but I think I understand what she was saying now.
Okay, Marla, do you want to just, for everybody's benefit, talk about that?
Yeah, so there was a question about PPE use for healthcare personnel taking care of confirmed or suspected COVID cases. Obviously a fit tested N95 is the gold standard for personal protective equipment, but if fit tested N95s are not available, CDC has described using a well-fitting surgical mask and eye protection as an acceptable alternative. So eye protection like a face shield for healthcare providers, and prioritizing those N95 masks for aerosol generating procedures.
Thank you. Thank you very much. Kim Joy is wondering about what you know about Italy's recent lockdown, their most recent lockdown. Have they had significant vaccine distribution or anything? Is it mostly due to the variants? I don't know, Nestor, if you've read much about what's going on in Italy.
No, nothing. I know that the UK variant is very prevalent in different countries in Europe, and they have issues with distribution of the AstraZeneca vaccine, but that's as far as I can tell. I haven't really read anything specifically.
Anyone else, Marla or Leslie or Cecilia, have any information or have any inside knowledge about what's going on in Italy?
I do know that France, at least, they stopped distributing AstraZeneca for a period of time because of the concern about emboli. I don't think that was the issue in Italy, but it does seem like vaccine uptake has been slow in a lot of Europe because of the fears around AstraZeneca, which, as far as I can tell, have not been borne out as true.
Thank you, Leslie. Leslie, Harry Seibold was asking earlier about the definition of long COVID. I don't know if, you've been talking the most about this, but I don't know if you can talk about if there's now a clear definition of when you can say somebody has long COVID.
I I don't know for sure. What I have generally seen is somewhere around 3 to 4 weeks out, if people are still having symptoms, that it's considered long COVID. And that we know that 6 months out, 10% of people are still having symptoms of COVID. And it is so variable between, some people who have just, mild lack of taste versus people who are still bedridden even from mild COVID a year later. So
Deborah, you were shaking your head. Are you using a specific criteria in your post-COVID clinic?
Now we're still trying to figure it out too. It seems like the guidance is variable.
Thank you. And Harry, did you have your hand up?
And then I was going to type it in there. So what do we name those people who were essentially asymptomatic, but some period of weeks or months later then develop symptoms? Because I've heard some of those described as long COVID or long haulers. So it just seems like a confusing term and set of terminologies that are not well defined.
So I do know that the ICD-10 code that I'm able to use is post-COVID syndrome. So I don't know if that's eventually what's going to be, because right now long COVID does not have its own ICD-10 code that I've been able to find. So
thank you very much. There is a question from Dan Saltman who apologizes for missing the didactic, but said, are there any updates on the Chinese subunit vaccine? I don't know, Nestor, you didn't really talk about that, but do you have any information?
No,
Nothing?
no, nothing on the Chinese. I know there are two vaccines, but I haven't really reviewed anything from it.
All right. And then Mark Epstein says that he can address the T-cell test for long haul. Mark, go ahead.
Yeah, this is out of Seattle. It's a company called Adaptive Biotech. And what they're looking at is the genetic material in T cells that indicate for T cell receptor production, previous exposure to SARS-CoV-2. And so that, I don't know how long after initial infection that takes to turn positive, but it has high sensitivity and specificity. You can do it at home or in a lab draw. It costs $150.
Great, thank you, Mark.
Mm-hmm.
All right. And let's see, we almost answered all of the questions, I think. I'm trying to see if there's any left. While I'm looking, I just want to let everybody know that we have a couple of upcoming COVID-19 echo clinics. The one is this afternoon from 2 to 3. It's the First Responder Resiliency Tele-Echo. And they're actually going to be talking about statewide efforts to address the opiate use disorder crisis. So that should be interesting. And then critical care is this week on March 18th. And the topic is going to be Eric Cry from our ICU here talking about ECMO for COVID. Let's see. And Mary, I'm interested, Mary Lynch asked an interesting question. She said, is there a compelling reason to vaccinate children? I don't know, Mary, if you want to elaborate on that question a little bit.
Not really, just that it just doesn't seem like the children get that sick overall as we look at it. And is it worth risking something that we don't know a lot about and how it's going to be long-term for children?
Great, thank you. Nestor, do you have any thoughts about that?
No, I mean, Marla can also add. I mean, I think the only reason or the most compelling reason in my view is for the herd immunity, because if you don't vaccinate children in many places, they're going to be, 20-25% of the population still susceptible. So the virus can, continue to circulate. And especially if the protection wanes, there may be elderly folks that can get it from a child. And, you have, the whole thing starting again. So it makes sense, once we demonstrate that it's safe in children, to increase the percentage of people vaccinated as much as we can, as much as it's feasible and safe to do, in my opinion, just to get that, population immunity to a level that actually crushes the circulation of the virus in the communities.
Thank you very much. And we just have a few minutes, but there's a couple of two interesting questions. And if we don't have time today, but if we don't get to them, about smell or taste. One is, can anyone discuss the metallic taste after the Moderna vaccine? How long it is supposed to last? I don't know if anyone has any information about that.
I do not.
Marla, have you heard anything about that?
No, I haven't heard that.
Maybe we can look into that. And then the other one is from Cecilia Dyden, says, any info on parosmia, the rancid smelling aftermath of COVID-19 that has many concerned?
The smell training is really fairly effective for that, which is people get 4 smells that they formerly liked. And twice a day they spend, 30 seconds, 15 to 30 seconds smelling each of them, smelling vanilla and remembering what vanilla used to smell like, and then smelling, lavender or whatever are the smells they like. And that one has actually fairly good evidence for treating it.
Excellent. Thank you, Leslie. Okay, we're right almost at the top of the hour. Thank you so much, everyone, for coming, and thank you to our experts, and we'll see you in a week. Bye-bye.